Our next topic is laryngeal carcinoma. So, first of all, the importance of this topic. There are many tumors related to larynx. Some are benign, like after this, we are going to study something called as vocal nodules, right, or vocal polyps. And there are many other lesions like ductal cyst, laryngocele is there, uh, and papillomas are there, but which are not so important. So that's why like that will not be covered in this lecture. I would like to tell you first of all the importance of this topic. The importance of this topic is laryngeal carcinoma. I'm talking about. If you will ask me like what is the importance of laryngeal carcinoma in all medicine, then I would say like it's not so important because after sitting in so many exams, I have never seen any question coming from laryngeal carcinoma. But if you will ask me what is the importance of this carcinoma in ENT, I would rather say yes, it is important from ENT point of view. Okay, so basically, overall, in medicine, it is not important because in ENT, we are going to study just few carcinomas. So that makes laryngeal carcinoma a little important. So, to start with, we had done the anatomy and physiology of larynx, okay, and we know what is supraglottic, glottic, and infraglottic region. And one of the thing I told you that the glottic region is the one which doesn't have any lymph nodes or lymphatic drainage, and that's why whenever there is carcinoma in this region, basically it present with what you can say hoarseness. Okay, so we had done the anatomy, we had done the physiology, and you can see the histology they are talking about. Uh, like, okay, talking about the importance first of all, then I will go on to the histology. Uh, Laryngeal carcinoma is 10 times more important in males than females, okay? And overall, its incidence, if you will compare it with all the body cancers, it is very, very, very less. Like 2% of the cancers are laryngeal carcinoma. And uh, you can see, all the laryngeal carcinomas, or 90 to 95% of the laryngeal carcinoma or malignancies, are basically SCC or squamous cell carcinoma. Okay, uh, and some of them, they are not that one, rather they are like spindle cell carcinoma or others. Okay, so it is more common in males than females, and it constitutes 20% of all head and neck cancers. Okay, not all the body. So now, what is etiology? The etiology is enclosed in this photograph, guys. Tobacco and alcohol, they are the well-established risk factors for laryngeal carcinoma. And basically, cigarette smoke contains benzopyrene and hydrocarbons, which are basically carcinogenic, and that's why there is increased risk of this carcinoma. And when it is combined with alcohol, it increases the risk 15 folds. So anyone who is just a smoker, he's at risk of getting laryngeal carcinoma. But anyone who is a smoker with alcoholic, there is 15% increased chances to get this carcinoma. Other causes could be human papilloma virus infection, chronic gastric reflux, occupational exposures, and head and neck radiations, right? So uh, now uh, the same things which we had done. I told you most of the cancers, they are squamous cell carcinoma. Then there are others, okay, which can cause. So, of course, like I'm not interested in going in pathology, histopathology, and all this stuff. Okay, but I'll be talking about more about the clinical symptoms and this thing. So, how we classify laryngeal carcinomas is basically according to the location. Okay, uh, like what is the location of the carcinoma? Depending on that, we classify them. So, talking about that, there is a classification which is used um, uh, too much. Is called as AGCC classification, and it talks about either like the site is supraglottis, either it is glottis, or either it is subglottis. Okay, so supraglottis, as you know, what are the where is the supraglottis, where is the glottis, and where is the subglottis? Now, the most important thing when someone have cancer of larynx, it produces it is caused by what you can say, it causes sound hoarseness. Okay, especially when it is in the glottic region. So uh, the most common place of laryngeal carcinoma is basically in the glottic region, or you can say glottic cancer. So supraglottic cancer is not so important, like it's not so common, you can say, right? The supraglottic, basically, whenever it occurs, it spreads locally, okay, and it can go to the base of the tongue even. It can involve the structures around there, around it, like hyoid, bone, epiglottis, and all these things, right? Even the thyroid cartilage. So, supraglottic, most of the time it is silent, but hoarseness is a late symptom in this one, because it is supraglottic, it is away from the vocal cords. And remember, when the carcinoma is affecting the vocal cords, it will become present with hoarseness. Of course, like throat pain can occur, dysphagia can occur, weight loss will occur, and all those things can occur. When it comes to the glottic one, which is the common one in majority of the cases, it is a small area, and of course it can spread locally, it can spread anteriorly, it can spread posteriorly uh, to the vocal cords, of course, right? And what it do, it basically fix the vocal cords. Okay, and as there is no lymphatics in this region, so nodal metastasis is a late finding, and most of the time the patients, they present with the hoarseness, and that's why hoarseness is the most common symptom in these patients, right? So why? Because why there is hoarseness? Because due to fixation of the vocal cords, the uh, vocal cords cannot vibrate much, and that's the reason, like the patients, they present with hoarseness. And then there is subglottic cancer. It is the least common one, and very rare one. 1 to 2% of the laryngeal carcinomas there in the subglottic region. So whenever it is in subglottic region, the symptom in these patients is basically stridor. Stridor is like, uh, and of course it can lead to laryngeal obstruction, or you can say breathing difficulty will be there. So a hoarseness can be there if it will spread to the glottic region, but that's the point, that it's a very, very, very late finding when the condition is too much widespread. So of course, like, there could be dysphagia, bloody sputum, sore throat, otalgia due to referred pain. Okay, uh, referred pain. So the pain is referred to the ears. Otalgia, breathing difficulties, aspiration, and all those things. Of course, like lymphadenopathy, the lymph nodes can be enlarged. So the same points which I was talking about, subglottic is the rare type. Okay, and see, like, these are the photographs of carcinomas you can see over here, subglottic region. So in physical examination, we go and we examine the larynx. We can see the cervical lymph nodes. We can do indirect laryngoscopy, flexible laryngoscopy, or panendoscopy. Or we can go for biopsy or imaging like CT scan, MRI, and all this stuff. So simply, like, a very important thing to know about this thing is simply, like, when you're going to visualize it by laryngoscope, um, you can see, like, clearly what's going on. So uh, you can see over here there could be laryngeal papilloma, which is a benign condition, not so important. It occurs due to human papilloma virus type 6 and 11, right? So laryngeal papillomas can also occur. There is juvenile type as well as adult type. Okay, not so important. That's why I'm not. One condition is called as laryngeal leukoplakia. Laryngeal amyloidosis can be there. So, so anyhow, remember about cancers. Whenever like we have to diagnose some cancers, first of all we do the investigations, and in this case, of course, you will go for history examination. In examination, you are going to do a laryngoscopy. Okay, and you can, like, nowadays there is flexible fiber optic laryngoscopes are available. They have a camera in them, and simply uh, you can visualize a tumor. Okay, you can examine the neck, you can examine the lymph nodes, you can do a chest x-ray, you can do a CT scan, you can do a MRI, of course. So, and of course we will take a biopsy, and then we will send to the lab, and then we would know what kind of laryngeal carcinoma is there. So talking about the staging, like once the investigations are done, we have to stage it. Okay, and how we stage, again the same staging is used. T and M staging. T is for tumor size, N is for nodal involvement, as M is for metastasis. So simply we don't have to remember this thing, but you can see like T1 where the tumor limited to one subsite, or T2 where it involves the mucosa more than one adjacent site, or T3 is when it is limited to larynx with vocal cord fixation, and T4, T5 like this, right? So this is the glottic staging, that is the supraglottic staging, and then there is nodal staging. This is nodal staging. Okay, so nodal staging when N0 is like no cervical lymph nodes are positive, N1 when single is when N2, N2AB, N2C, N3, and then we check for the metastasis. Either it's limited there or either it's widespread in the body. So simply by this way we basically do the staging, and once the staging is done, we go for the treatment. So of course, like the treatment depends on the site of the lesion, the extent of the lesion, the presence or absence of the nodal or distant metastasis. There are many options which are there. Radiotherapy is there, surgery is there. Nowadays, endoscopic carbon dioxide laser excision is there. Okay, why? Because we have to preserve the larynx. Okay, because if the larynx is lost, basically your voice box is lost, and when you don't have the voice box, you cannot produce voice, so there is no phonation, so there is dysphonia. So surgery can be done, and like of course, like laser surgeries are available now. Partial laryngectomy can be done, total laryngectomy can be done. So uh, before, like most of the patients who have laryngeal carcinoma, what they do is like total laryngectomy. So when they do total laryngectomy, basically there is no voice left. Okay, and I will tell you like what they do to produce the voice. But nowadays, like the surgeries which are done is a conservative type of surgeries, in which like we try to preserve the larynx as much as we can. So like excision of the vocal cord can be done, or excision of the part of the larynx where the carcinoma is there. We can do that, and radiotherapy can be done after that or before that. Okay, so a total laryngectomy, you can see, can be is performed like in the patients when there is T3 lesion with cord fixation, or all T4 lesions, or when the cancer is reached the thyroid or the cricoid cartilage, we go for that. So, and then the radiotherapy comes. Radiotherapy is also available, and that is used like especially to preserve the larynx. Sometimes radiotherapy and surgery are combined together as well. And as I told you, like nowadays, this laser excisions are also there, which are good in preserving the what you can say the larynx. Okay, so nowadays that thing is also there. So simply, you can see over here. This is they are performing the laser surgery to cut down the tumor, and this is like partial laryngectomy, in which they are going to remove a part of the larynx. So this is horizontal hemilaryngectomy. What is the thing? They can excise, and vertical hemilaryngectomy. See, like they can remove the larynx. or total laryngectomy, of course, like when there is they remove all the larynx. So once they remove all the larynx, what is left is a tracheostome. Like they leave a small hole here to breathe in and breathe out. Okay. So like in the normal people, what happens is you can take the food from here, you can take the air, but after surgery, after removing the larynx, you can see you can take the food from the mouth, but the air goes from this tracheostome, the stoma, the hole which they leave behind. Okay. So uh, whenever they do laryngectomy, what is done? See, they leave a hole like this. Okay. So see, like there is no connection between the mouth and the airways. The air goes from here. Of course, it leaves the patient like susceptible to different infections. So after that, what is done? We do a voice reconstruction. So electrical larynx can be used. Blom-Singer is a one of the way, as well as you can say there is esophageal sound techniques are also there. So to tell you more about this one, uh, like a lot of you can see here. Okay, this one is she's using a electrolarynx. This is battery operated device which is having a vibrating disc, and they can put it here, and due to vibration it produces sound. Okay, so of course then you can articulate that by your lips, but of course, like the sound quality is not so better. So this is like a transcervical electrolarynx. Okay, esophageal speech is what, like in this technique, what they teach the patient is to teach them how to swallow the air inside and then slowly release ejected back from the esophagus to the pharynx, so that the patient can speak around 6 to 10 words in one go. So of course, like why voice is not so loud, it is sorry, voice is loud but it is rough. Okay, but the good thing is it is understandable. So they teach them how to take in air or swallow air, collect a little, and then how to take it out and try to talk. So this is one of the thing. And uh, other things are also there. Yeah, this one is like intraoral electrolarynx device, a new device like which they can put it inside the mouth, and this is the one which uh, can produce sound, right? So it is like, you can say, another type of artificial larynx, like which is a transoral device which can produce sound. So this is also there, right? Which can be used to make. So this is like how we reconstruct the sound. Then there is tracheoesophageal speech as well. In this one, like the attempt is made to carry air from trachea to esophagus or hypopharynx by creating a skin fistula, a skin line fistula. But of course, like nowadays, this processes are also available, which are called as Blom-Singer processes. Basically, they shunt the air from trachea to the esophagus. So these things are available. So all these things are the ways to reconstruct the voice. So the last topic which we are going to study today is called as vocal nodules and vocal polyps. Okay. Uh, Now you can see over here. Um, this is the normal larynx. This is like the normal resting anatomy, and this is like the normal phonation. They are doing laryngoscopy by how they are fiber optic laryngoscopy. So that's how they took the images. So I don't think so. Yeah, like you need to know this, but the true vocal cords lining is pseudostratified squamous, right? So this is like all the etiology, histopathology they are showing you. So what is nodules, by the way? Um, Vocal nodules are basically also called as singer's nodules or screamer's nodules. So these are localized benign superficial growths on the medial surface of the true vocal cords and commonly believed to be the result of phonotrauma. So the professions like teachers, singers, like who use their voice a lot, they may get this thing, and their size is less than 3 millimeter. Okay, usually their size is less than 3 millimeter. So now the important thing is one of the thing, you can see over here. This is a nodule. This is a nodule. This is a nodule. Okay, so nodules are bilateral, and they're classically at the junction of the anterior one-third and posterior two-thirds of the true vocal cord. Etiology is vocal abuse and misuse, and simply due to abuse there is hemorrhage and submucosal edema, which basically become fibrosed, and that's what make the nodule. So what are the symptoms in these people? Like there is hoarseness of voice as well as voice fatigue. Sometimes pain in neck or sore throat can be there. So then there is vocal polyp. Okay, now vocal polyp, of course, like it is well differentiated, hyperplastic, benign pathological structure of mucous membrane which size is more than 3 millimeter. Now the etiology in this one is smoking and allergy as well as phonotrauma. You can see two more things are there, and it is very common in males between 30 to 50 years of age. And there is sudden shouting with hemorrhage and submucosal edema, and the location is involve the free edge of the vocal cord mucosa, and you can see like how they look like. See, the size is big, or this one. Okay, so the symptoms somehow remain same: hoarseness of voice, break in speech, low pitch speech, loss of power part of voice range, strain during phonation, diplophonia when there is echoes in the sound, or strident and choking, but they are very rare when the polyp is so big. So you can see the difference between the nodules and the polyps. Nodules are less than 3 millimeter, polyps are more than 3 millimeter. Nodules, the location is different, polyps, the location is different. Okay. And the age group is also different for both of them. So the differential diagnosis can be Reinke's edema. It is bilateral diffuse polyposis. It is basically a collection of edema fluid in the subepithelial space of Reinke. And it is also found in vocal abuse and smoking. And both of the vocal cords, they show symmetrically swellings. And how we treat them, basically they excise, they cut them off. And it could be intubation, Ulce granuloma. The people, when they intubate them for prolonged time, they may have this thing. Or it could be leukoplakia. Leukoplakia is basically epithelial hyperplasia, and it is mostly on the upper part of the vocal cords. These are the differential diagnoses. Okay, it appears white in color, or it looks like a wart, white wart, simply. Okay, or it could be like any other things like amyloid tumor or contact ulcer. So all the things that comes in the differential diagnosis. So simply, whenever we have a patient who have hoarseness or things like this, we take the history, we ask the profession, we ask smoking, we ask allergies, and then we go for examination and we do laryngoscopy, no matter what type you're doing, but simply you are examining, you are seeing the, what you can say, the vocal nodules, how they look like. Okay. So no matter what you're doing, what is the way, like this one is the indirect laryngoscopy to see the vocal cords. And this is a rigid laryngoscope, and this one is a flexible, like the new one, which have a camera, and you can simply see that. Nowadays video stroboscopy is also there, in which like there's a bag like this, and they can visualize everything. or microlaryngoscopy is also there, in which like they can see the microscopic size of the vocal cord. Okay, so now like how they treat it. First of all, we educate the patients for voice hygiene. The thing will sound a little weird to you, but like there is something called as speech therapy or voice hygiene is taught to them, how to use voice, and then there is medical and surgical treatment as well. So what is vocal hygiene? Like, maintain adequate hydration, drink enough water, minimizing exposure to noxious chemicals, no smoking, avoid excessive shouting, screaming, or other loud voices. And what is voice therapy? A behavioral intervention technique that makes use of vocal exercises. So medical treatment is, we can give them steroids to reduce the inflammation. Okay, we ask them to take some rest. Lifestyle modification is also important, and surgical treatment, of course, to remove that growth. And surgical complications are also there, of course, like you can damage the vocal cords and you can damage the adjoining structures. So this is when we do indirect laryngoscopy. These are the structures which we can see when we do an indirect laryngoscopy. By the way, like in our medical school, I got a supply in ENT because in my short case there was a patient, an old person, and the command was to do an indirect laryngoscopy. So I did everything correctly, but the instrument which I choose was basically not an indirect laryngoscope, rather it was an instrument to do rhinoscopy. So guys, it's your homework. Just Google and see what is the difference between indirect laryngoscope and rhinoscope. They are, they look very, very, very similar. Just there's a small difference in the angle of both of them. So on that basis, they failed me in this thing. So thank you so much, guys, for listening.